Hi, I'm Marshall Wolf, and today's talk is a summary of a session I gave on Morning Report. I'm going to just give you the academic and lecture part of the session. What we did at the end of the session was actually had the audience participate in a typical morning report so they understood what I was really discussing. Now, I think there are two main topics for a morning report. One is a chance to teach the clinical method, and the other is to teach about certain topics. In terms of the clinical method, I think that the goal is to start with a history, to come up with some hypotheses for the patient's problem based on that history, to use those hypotheses to further enhance the history, then having developed a set of hypotheses to focus the physical examination so that one looks at those aspects of the physical examination which would allow one to decide which of the hypotheses you formulated from the history are more likely to be true. One also, after having done the physical, then goes back and changes the hypotheses and then may want to do additional history. Eventually, having done a thorough history and physical, then one proceeds to the laboratory, and one does studies which are based on one's hypotheses in order to distinguish between them and identify the patient's diagnosis, or the most likely diagnosis. In terms of the topics for a morning report, we can focus on the diagnosis and its differential diagnosis. We can talk about management of a problem, treatment of a problem, and sometimes just review an illness which people have not reviewed in detail or with a database in the recent past. Morning report in the days of yore, when I trained, was actually not a very academic activity. It was really a chance for the residents who had admitted the previous night to tell the physician-in-chief what sort of patients had been admitted. Dr. Thorne, who was the physician-in-chief at that time, was an endocrinologist. During the course of the inventory, if a patient had an endocrine problem, he might ask for more information, but by and large, it was rather a sterile review. In the Brownwald era, that changed. We decided rather than to just list cases, we would do 2 or sometimes 3 cases and try to look at them in some detail. Eventually, we figured out that it worked better if we used a single case. The residents, or usually the chief resident, would select a case, review the literature, and then present it in bits to the house staff and the faculty attending. The discussant, who was not given the diagnosis prior to the session, was asked to stimulate discussion of the case and eventually, if appropriate, to supply his expertise. A resident scribe was always asked to summarize the history and physical so that late arrivees could participate in morning report. And then finally, the last thing we did as a variant on this is we would present morning report monthly in a grand rounds format. In this format, rather than the residents being asked to discuss the possible diagnoses, the faculty would be asked to do so. And usually after a half hour of discussion, we would have 2 experts review the symptom and the diagnoses. In the most recent period, we've also introduced a interns report so that weekly we have a session where more basic problems in diagnosis, therapy, and topics are reviewed with interns only. Now, the faculty usually is pretty anxious before they've started to give a report because they assume they have to supply the answers. But in morning report, as in teaching rounds, we really want the faculty to help identify the appropriate questions. It is very useful if the faculty knows some members of the group so that they can ask questions and get a discussion going. It's very important for the faculty in this format that when residents give a suggestion which is not right on, that they don't penalize the participant for having made such suggestion. And finally, we ask the faculty to both get feedback from the chief residents about their role in report and also give feedback to the resident who presented report. This role of the faculty gives them a great deal of personal satisfaction, and I think it's also fun for the resident participants as well.